this will be a cholecysto enterostomy, and on the image you can see the gallbladder here, very nicely seen. You can see the liver adjacent to it. And the gallbladder is nicely up against the bowel wall. Of course, this is a mobile organ. This is a normal gallbladder. It is not adherent to the bowel wall. And we're going to create this cholecysto enterostomy using a lumen opposing stent. So this is a special stent that's very short. It's only 1 centimeter long, and it has two flanges that are perpendicular and double walled, perpendicular to the axis of the lumen itself. This is the AXIOS stent by Lumina, made by Lumina. We're going to deploy this stent using the HOT system, the HOT AXIOS system. That system is not yet FDA cleared, but should be cleared later this year. The system that's currently available in the United States is called the cold AXIOS delivery system. So the stent itself is FDA cleared, but the delivery system, the hot system, is not yet cleared, only the cold system. But we're going to show you the hot system because this system is the ideal system because it allows the endoscopist to access the gallbladder lumen and immediately deploy the stent, all using one catheter system. So it combines the steps of access and stent deployment. You don't have to place a guide wire. You don't do any exchanges over a guide wire. It's all done very smoothly, literally in one step.
Now,
all right, so now let me just show you the
Can I
anatomy a little
interrupt
bit
you?
better.
In the human, you're typically placing this at the apical portion of the bulb, post-bulbar. Where's your typical location?
Yes. So in the human, this would be in the bulb, very typically at the apical portion. But obviously, you're going to look for an area where the gallbladder is in nice apposition against the bowel wall. But that's usually the apex of the bulb. You also want to deploy your stent a little away from the pyloric ring. So you don't want the stent to deploy right at the pyloric ring. So you do want to confirm endoscopically that you're a little bit away, maybe a centimeter away from the pyloric ring. All right, let's just put a little bit of water in here so that we can just show you the wall of the bowel, because you do want to always go through a series of steps and just confirm. Here you can see the water going into the lumen. Do you see that? And you can see then that the wall thickness is very thin here. So as mentioned, the length of the stent itself is 1 centimeter. So this is just a few millimeters. Obviously, we've got ample room. But if you do have a thickened wall, then you will need to confirm that the wall thickness does not exceed 1 centimeter. So we're going to now take off the valve here because this delivery system will lure lock onto the echo endoscope no different than the FNA needle does. So it really works analogous to an FNA needle. We're just advancing this. This sheath is actually hydrophilic coated, which means that if you just wet the sheath, it really slides very easily down the working channel. This is a swivel lure lock, which allows you to actually swivel the orientation of the device just in case you want to bring it more towards the operator so that you can see the front of the device. This device consists of two components. There are two hubs that control the two components. So there's hub number one that advances the sheath forward. So that's the sheath that contains the stent itself. And at the very tip of the sheath is a thin wire, a cautery wire, diathermic wire. And when we activate this wire, it's going to allow us to penetrate with cautery, but only delivered along this very thin wire that runs alongside the very tip of the sheath. The sheath itself, the very tip, is bougie-shaped as well. And that wire also runs along the very tip. So you're really applying the cautery in a very focal area that's just enough to allow you to penetrate the tissue with minimal collateral cautery. In fact, you should see virtually no cautery at all using this device. And the other component here releases the stent itself, and you release both the distal and the proximal flanges completely independent of one another. And that's a very important feature of this device.
Ken, how wide are those flanges when they're fully released?
So they're about twice the diameter of the diameter of the lumen of the stent itself. So this is a 10 millimeter diameter lumen, a 1 centimeter diameter stent, and so the flanges will be about twice that, around 20, 21. All right? So now, the first step, we're going to unlock the sheath itself here. So you just turn this to the unlock position. I don't know if you can see that with the camera here, if it can zoom in a little bit. So, and next step is I'm going to advance the sheath forward. And as I advance the sheath forward, I'm going to look with EUS, and you can see at the very tip here, right here. And Tom, why don't you flip on the Doppler? So you can just sort of use Doppler just to confirm. Well, the reason why is there's water in there. So there's don't let that deceive you. There are no blood vessels here. All right, so you can see the tip, and you can even tent in just a little bit like this, see? And I'm going to apply cautery now. We're using pure cutting current. That's very important. Use pure cut current. And as I step on the pedal, I'm going to go into the gallbladder. All right, I'm already in, and I'm a good distance in, and now I'm going to lock. So I've locked the sheath, and the next step is now to deploy the distal flange. So I have access. I'm going to unlock this second hub up here, and I'm just going to retract back under, keeping my ultrasound guidance, pull back, and you immediately see the distal flange deploy. See it? It's like a disc here. It's very echogenic, and this is the inner wire that controls the tip. The tip of the device is still right here, the bougie cautery tip. This is the stent that is now deployed, and the next step is to just pull back until this disc here is snug up against the wall of the gallbladder. And as soon as you see it deform just a little bit, I'm going to lock this in place like this. I'll just pull it back just a tad more. I'm going to lock. And now I'm going to deploy the proximal flange. I'm going to keep my EUS view. I'm not going to switch views. Keep my EUS view. And when I deploy this proximal flange, it's going to deploy in the working channel of the echo endoscope. It's deployed now. It's in the working channel. And now I'm going to switch to my endoscopic view. I'm going to unlock this sheath here. And as I'm pulling back to get my endoscopic view, so I'm going to give some air now. I'm going to look, and as I'm looking, I'm going to advance the sheath forward. There it is, and it's now deployed. So now the proximal flange has fully deployed, and on the endoscopic image, you can see the delivery tip. I want to show the tip very quickly, Tom, if I could. You can see the tip of it. It's already draining bile now. That's why you're losing your view. But see, this is the very tip of the device right here. Sometimes I can show you if you rotate it a little bit. You can see the two wires. You can see the bougie-shaped tip. See at the very tip, there's a metal wire that runs along the circumference. And that allows the very focal application of cautery just to the tip. And then on the side, the wire runs diagonally. So you're applying cautery just along the two wires. This is unlike the cystotome, which has a metal ring, a solid metal ring. So you're applying a lot of cautery along a large surface area. The purpose here is just to enable easy access. All right, now there's no guide wire that I placed, although you do have the option if you wanted to have a guide wire in here, you could place a guide wire through this as well. We're just going to leave this in place now. It's draining the bile beautifully. You can see that. We'll remove the device now. And I'm going to show you, if you switch now back to the EUS large. So on EUS, I'm going to show you once again the distal flange inside of the gallbladder. See, there it is. This is the gallbladder. It's draining. It's decompressing. So imagine this is the patient with cholecystitis, and the gallbladder is filled with pus. All that pus would now be draining, and you can see some air. This is the artifact that you see inside of the gallbladder. These bright spots that's air artifact that, of course, we're instilling now from the bowel lumen. So this is the distal flange. This is what we call the saddle, and then as I pull back, you have a nice view then of the proximal flange. And it's right up here. That's the proximal flange here. All right, so there, I'll try to get a view where you can see both flanges. Proximal flange up here, saddle, 1 centimeter long, and distal flange. There's another view for you.
So Ken, this is a pretty.
All right, so we drained this gallbladder, and it took literally what? Just a couple minutes, right?
Yeah, I was going to say this is a pretty
And
swift,
this will
efficient
expand.
procedure, isn't it?
I'm sorry?
This is a pretty swift, efficient procedure, isn't it?
Well, the whole concept here is to make this as easy as possible, to eliminate steps where you do over-the-wire exchange. And that's where things can go wrong. That's where you can get bile leak. So you will get zero bile leak using this method. And the reason is because as soon as you've accessed the gallbladder, your sheath, of course, is plugging up the hole. Then you deploy your stent, and then you release your stent, and the stent is expanding, so it seals off the fistula that you've created. In addition, the stent is fully covered, so of course the covering seals it off, and the covering also tamponades any bleeding that might occur. If you want, you could dilate the stent immediately afterwards up to 10 millimeters, and you could go inside of the gallbladder and you could perform cholecystoscopy. We're not going to do that now because I actually want to use the remaining time to show you a gastro jejunostomy. But to do that, I need to get a little bit of water inside of the. Now this is a pig, so it's a little tricky getting into the bulb here. I'm going to try to do that if I can. There, I think I'm in the bulb now. All right. And let's go ahead and put as much water as we can in here. What we're doing now, and this is the method that we've been using to do gastro jejunostomy, is to try to fill up it's really the distal duodenum and jejunum with water, so that afterwards, when we look transgastrically, we'll be able to see the lumen of the duodenum, our target, right? So just a quick moment here to fill up as much water as I can. Maybe one more, and then let's see if we can see the duodenum, and then see if we can do the gastro J. A little more, okay. Just give us another moment here. Just put a little bit more water. Now, there are other ways to do this. You could pass a 20 millimeter balloon. I've done this. Pass a 20 millimeter extraction balloon into the duodenum, the distal duodenum, or close to the duodenojejunostomy, jejunal transition. That's where you want to create your gastroenterostomy. So we call it sometimes a GJ, but technically it's not a GJ we're creating. It's a GD. It's a gastroduodenostomy because we're not really going beyond the ligament of Treitz. We're still in the distal duodenum. We're in that fourth portion of the duodenum. Think it's good? We'll give a little bit of glucagon just so that that water hopefully stays in the duodenum. And let's get a little simethicone if you have it, or we just sort of see if I can pull out some of this air here quickly. So just stay with me for another moment as I move around. There's just a lot of air inside of the bowel lumen. So we do have some loops of bowel, but these loops of bowel contain air. We have to look for an area where there's water. Here's what I suggest. Why don't you see if you can go back to one of the rooms? I'm going to find a nice loop for you, and then you'll come back to me and I'll show you the gastroenterostomy.
Okay, that sounds good.
So, the small bowel is very mobile. So this changes by the second. But you can see I've got a loop of small bowel here. I'm going to enlarge it a little bit for you, right there. And there's the AXIOS, the hot AXIOS sheath. This is a 20 millimeter stent that I have. Now the ones that are available currently in the U.S. are only 10 and 15. So I'm going to go into the small bowel, same principle, use pure cutting current. I'm in, all right? Okay, I'm going to push it down a little bit like this. I'm going to lock. I'm going to deploy the distal flange just like you saw before. right, it's deployed. I'm going to pull back until you see that disc. Look at it. There it is. It's coming. All right, I'm going to snug it up now. Wait till it deforms a little bit, like this. I'm going to now lock again. I'm going to deploy the proximal flange in the working channel of the echo endoscope. I'm going to unlock again the sheath. We're going to switch to the endoscopic view. Switch to the endoscopic view now, please. I'm going to give air. I'm going to very slowly advance the sheath forward. As I'm looking, there it's coming. It's out. There is our gastroenterostomy. This time, we're going to dilate this up to 18 millimeters. 18 to 20. We'll dilate this to 20, and we will then go in and intubate the duodenum or jejunum.
So Ken, how many of these have you done? Palliative gastro J's, or what the indications
I stopped counting a long time ago. No, I've done them using various methods. Recently, we published on a notes method actually using this.
And are you doing it mostly for palliation of malignancy, or are you doing it for motility disturbances, or what's the most common indication?
Right, I've got a bunch of different voices coming across here, but I did hear the question, is this mainly for palliation? And yes. So it's still too early, although there's great interest in some potentially for obesity or diabetes, but currently it's being used only for palliation of duodenal obstruction, and mainly in patients where, for whatever reason, a duodenal stent would not be the ideal solution.
Okay, good.
All right, so now in just a moment, I'm going to, so you can see the lumen. And I'm getting a little bit of an echo, so I'm sorry here.
So Ken, we have a question from the audience about accessing the bypassed stomach in the patient who's had a Roux-Y gastric bypass in order to perform an ERCP.
Yes. So when this 20 millimeter is out, I have some echo, so if you don't mind turning that down, because I sort of keep hearing myself. When this 20 millimeter is out, then I think this will work very nicely for that. I have done this using the 15 millimeter, but the problem is that the 15 millimeter, there's a lot of friction between the duodenoscope, which, as you know, is it's a large diameter instrument, and the stent. So there's a risk that you may pull the stent out if you immediately perform your ERCP after deployment of your stent and dilation of the lumen. So if you're going to use the 15, you have to wait a few days, ideally about a week, before you perform. There we go. So let's go ahead and dilate this up. Before you use the fistula tract or use the AXIOS as a port to access the native stomach to perform your ERCP. And wait 1 second. Let me just pull back just a little bit because it's sliding up inside. Let me just pull back just a tad more. So sometimes the balloon wants to migrate forward. Try it again. Go ahead. Yeah, go up. And I think it's migrating forward. Let me pull back just a little bit because I want to make sure that the balloon dilates in front of the stent. I'll just pull back just a tad more here like this. Okay, now try. There we go. Yeah, this is good. All right. So you just want to make sure that your balloon doesn't get sucked in as it starts to dilate. So now we're dilating. What is this, Tom? Great. So you're at 18 now? So we're just dilating up the tract. And try to keep it, perpendicular to the wall. That's 18, all right? Let's go up to the next step. So this is a 20 millimeter. So we're going to go all the way up to 20. And then go up to 20. And then after this, we're going to switch out for a gastroscope. And then we'll go into the the jejunum, or distal duodenum, depending where we're at. All right, go down. So I think this could be a very elegant way of enabling us to do ERCP in patients who have a prior gastric bypass. My experience is that if you remove then your AXIOS stent, and it's within the time frame of about a month, the fistula tract closes completely. So you don't have to worry about a permanent fistula forming. Just want to show you, here's a view of the jejunum. This is using the echo endoscope now. It's an oblique viewing scope. But we're going to switch now, and we will go in there and perform a jejunoscopy.
Yeah, it looks pretty slick.
But if there were any concern about a fistula forming between the gastric pouch and the native stomach, well, then you could just use the Apollo and just suture the fistula. I think that would be a reasonable solution were that to be a concern. But my experience is that if you remove the stent within a month, the fistula closes down right away. Okay, I'm passing the gastroscope. It's a little dark. Can you make it brighter, please? I don't know if the audience has it fairly dark. All right, there's a view of the Lumen opposing stent. I'm using this as a port now to enter into the jejunum. Now there are two limbs, right? Afferent and efferent. So if I go down this limb, I'll probably get back to the duodenal bulb. If I go down this limb, I go down the jejunum. These are the two limbs. And, in theory, this not only bypasses the duodenum, but if you could create a fistula between the stomach and a more distal part of the jejunum, this could also facilitate enteroscopy. You would immediately have access to a more distal portion. The challenge there is how do you identify that more distal part of the small intestine? And that's why I developed the notes guided approach, where you use EUS to basically enable you to access the peritoneal space very safely. You instill water into the peritoneum. You use EUS to get access to the peritoneum. You pass a guide wire into the peritoneum. You use a balloon, and you create a small fistula large enough to allow you to pass a double-channel scope into the peritoneum. Now you do peritonoscopy, and under direct endoscopic guidance, you grab that limb of jejunum that you want to create your jejunostomy to, no different than the way the surgeon would create a gastro-J. And then you deploy your AXIOS stent, the distal flange, directly using a needle knife, or you actually use a hot AXIOS. You can go directly in, deploy your distal flange, pull it up to the stomach, and deploy your proximal flange. So you will have created what's identical to what you're looking at right now, except using a notes approach.
Okay, thanks, Ken. We're going to switch to a different room now.
Great, thank you.